try and respond to the call need for better conversations about the use of health information. I know from previous research that a lot of people are very supportive of the idea of the use of patient data, health information in search, but they actually have a very low awareness about how data is used even within the NHS, let alone for any purposes beyond it. And so that's sort of what understanding patient data is all about. I work at the Wellcome Trust, and Wellcome is hosting the new initiative, which is going to run for 2 years because we think that 2 years is kind of a decent length of time to dedicate serious resource to this. But also, if we haven't shifted things in that time, we're probably not going to. And the key aims of this initiative are to support discussions with public, patients, clinicians about the uses of health data. We're not running a public information campaign. It's more about providing the tools and resources, helping different people have those conversations. One of the key things we're trying to do is start providing some objective evidence about the benefits of health data usage. There's lots and lots of different examples of case studies that are all over the place.
Sorry to interrupt, Natalie.
Sure.
I know, having asked you to move at a fair canter through the slides, I think I've been asked you to speak a little too fast.
Sure,
if you can slow down a little bit,
I'll slow it down a little bit. Yeah, sure. Okay, sorry.
Thank you. Thank you very much.
One of the areas we're working on is to do with trying to you can talk about the great benefits that can be had from using patient data, bring together case studies that are out there in the public domain at the moment, make them consistent, pull them together so that there's a really nice sort of bank of examples of what the benefits are of using patient data. We also think it's important to be honest about the risks and the safeguards that are in place to ensure that patient data stays safe. So you can see from the slide what the different aims are. I won't go through all of them in detail.
Natalie, I'm sorry. Instruction to everyone, please go on mute. We're listening to background noise from someone on the broadcast. Go on. Thank you very much for obliging. Back over to you, Natalie. Okay,
thank you very much. So you can see from the slide what our aims are, and as I said, we're going to sort of work over the course of the next 2 years. Based at Wellcome, but funded also by MRC, ESRC, the Department of Health and Public Health England. So, big challenges that we have in trying to have conversations about patient data and how it can be used is there is currently an extremely bewildering array of terminology that's out there. Some of it is deeply technical, and very often we find that if you use terms like pseudonymized or coded or masked or encrypted, they may have a very specific technical meaning in practice, but actually for the vast majority of people, they don't really understand what these terms mean. And if you're starting from a point where you don't understand what the terms mean, inevitably that's going to create suspicion, loss of trust, loss of caution. And the slide I've got up at the moment is just an exercise I did over the course of about a week, where I looked at all of the different terms that were currently out there for different kinds of levels of identifiability of data, what the processes are around anonymizing data, different terms for consent, different kinds of governance mechanisms are out there. It's a really bewildering and confusing array. And we think that if you're going to start trying to have conversations about how health information is used, you've got to try and simplify the language a little bit. That was our starting point, really, is trying to sort of get a better sense of what kind of language you could use that would be accurate, but actually also accessible and meaningful to people. One of the challenges to trust and to public confidence in how data is used come when you say, oh, this data is anonymized, and then someone else comes along, typically a privacy group, something like that, Med Confidential and so on, and says, well, actually, if you link that data source with a different data source plus this as well, then could re-identify individuals. Suddenly the term anonymized ceases to have any meaning. So we're trying to create some language that will hopefully avoid those kinds of problems, the complexities of using different terms. So far, we started off with a creative workshop. We want to get people who were very good at using language, using words, but they didn't necessarily have a grounding in data and data use. So we had people who work in advertising, technical writers, science journalists, people who write sort of technical manuals and so on. We had the advertiser that came up with the "once you pop, you can't stop" slogan from Pringles. So we wanted to get them in a room to start the problem, see if they could come up with some alternative terms that might cover the sorts of terms we wanted to talk about. In a way, it was gratifying that they found that really difficult to do, but come up with some language to use. And we explored those alternative terms with various stakeholders, researchers, people who use data all the time, and experts, including the IGA. We then sort of honed the language and then ran some focus groups with the public and a variety of health professionals to sort of further explore these terms. So we wanted to come up with a set of terms for talking about data use that works for everyone, both professionals and the public. Reinventing the wheel. We don't want to add confusion to the landscape or add new terms that are just going to make things more complicated for people. So that's the sort of methodology of what we've done so far. This is the sort of framework we were thinking of. So the terms that we wanted to come up with that would hopefully improve the language and the landscape. First of all, the overarching term. Do you talk about patient data? Do you talk about health information? Is the word patient a useful one to use? So that was the first thing that we explored. Secondly, the purposes for which data may be used. At the moment, the terms direct care and secondary uses or purposes beyond direct care. We want to see if those were words that actually sort of made sense to people. And third, I think this is where your contributions will be particularly helpful, the levels of identifiability of information. So identifiable at one end of the spectrum, de-identified individual level, and then the anonymous aggregated data at the other end. Are those terms that people get, that they understand, or do we need to come up with some different ways of describing those levels? So I'll run through the first two categories relatively quickly. So firstly, the overarching term. We tested a huge number of these, but actually patient data or patient health information, both of those terms seem to work actually quite well together. Although data and information do technically have different meanings, in terms of the public mind, actually they can both work quite nicely in conjunction with one another. We did explore whether the term patient was problematic. We tried partner, consumer, citizen, but they just didn't test as well. People, particularly citizen, people didn't like that. They felt it said a little bit George Orwell. So we found that actually using both patient data and patient health information as terms overarching was very, very helpful. The key thing with patient health information is to ensure that health information on its own sounds like it's information about, information for you rather than information about you. But having the word patient at the beginning of that did help people understand that this is information about them. For the person may be used, this one actually came out very, very clearly. Direct care doesn't mean anything to anyone. It was striking how problematic that term was in terms of people understanding. They thought that it sounded like an insurance company or credit card or something like that. Individual care came out very, very clearly on top. So rather than using the term direct care, the term individual care, people got it very quickly. They understood exactly what it meant. So that's a nice, simple one that we can really promote. Rather than talking about using data for direct care, individual care seems to work much, much better. Given direct care doesn't work, the term purposes beyond direct care or secondary uses didn't work particularly well either. We tried lots and lots of different things here. The key thing we wanted to get across was to ensure that there would be no surprises. So there's lots and lots of different purposes for which data may be used, and trying to come up with a phrase that would encompass those such that people wouldn't be surprised to find out that data had been used in a certain way if they were aware of this kind of overarching term was pretty challenging. The term we came up with that seemed to cover things best is a little bit clunky, but it was improving health, care and services through research and planning. It's a relatively long phrase, but it does seem to cover all the bases. We tried different permutations of all of these, but that was the one that seemed to cover things the best. And I was very keen to ensure that there were no surprises here. So if you're using this term, improving healthcare and services through research and planning, we did some quick fire testing of potential different uses of data and asked people, did they think that their uses of data fell under this umbrella this umbrella phrase. Whether or not they approved of those uses of data wasn't the point. It was more, if you'd heard that data could be used for these purposes, improving healthcare and services through research and planning, would this sort of fall under that category? And in the vast majority of cases, the answer was yes. One that did cause a bit of confusion was whether GP practices trying to reduce their drugs bill by using data to kind of determine which kind of drugs they should use for arthritis. But I suspect that might have been something to do with the wording, and maybe if we'd removed that last sentence at the bottom, reducing their drugs bill, then maybe it would have been clearer. I think the reassuring thing from all this work, though, was that using this phrase means that people understand different kinds of uses, including some commercial access, including pharmaceutical companies and so on. That phrase does actually capture those types of uses, which I think is incredibly important. So yeah, the first two part of the framework that we have so far. I'm on now to talk about the levels of identifiability, which I think is an area that you'd be particularly interested in. So this is a really complicated area, and we really struggle to know how best to approach this. There's lots and lots of different terms that are used. We categorize things into these three different levels. On the one hand, identifiable, so individual level, identifiable information. We've got an IGA definition and several other terms that are used to describe this. And the second two categories, we wanted ones that would fall under the anonymization code. It wanted levels of data that would be captured as conforming to the ICO code of anonymization. So that was also standard for those. On the one hand, still individual level, but identified in accordance with the ICO code, and on the other hand, aggregate level data. And these are kind of levels of identifiability that are extremely hard to kind of get across to people what they are and what they mean. Lots of other different terms have been used. We've got de-identified for limited access, de-identified data for publication, and so on. It's hard to actually explain to people what those are. Really struggle to know how best to come up with some words that would make this a little bit clearer to people for the general public. So the structure. What we found is that using images is incredibly effective, and it works so well. So we obviously aren't going to be able to use Lego in our final outputs. So forgive the slightly not particularly well defined images there. So there will be images of people, but the images we have here very, very quickly and easily got across to people what the concepts were that we were trying to convey. So on the left side, you have the identifiable Lego man. He's got. You can easily.
Sorry to interrupt, Natalie. I think you need to press the button. I think you need to press the button to move the slide forward.
Oh, is it not advanced?
No.
It's just on my. Not on my one. Are you using a blank screen?
No, we have a blank screen. It stayed with your new framework. We haven't moved to the Lego man, which is a great shame, because I know everyone else wants to be the Lego man. I wonder if you could pass the control ball back to us.
Sure. Let me do that. Where are you?
I can see the Lego man beautifully.
Okay, so I'm glad. Just carry on then, Natalie.
Shall I just carry on? Because everyone's through the
Yeah, the problem is with us. Thank you.
Okay. So we have the Lego man on the one hand, very identifiable. You can see lots of features about him. The middle category was just fantastically useful for explaining to people. It's still individual level. You can still see it's a person, but it's blurred. You can't necessarily tell who that person is. The other thing about this particular level is you could make the picture more or less blurry depending on how de-identified it is. You could also potentially take pixels out so that you have which will help explain the concept potentially of digital re-identification. You could have sort of certain bits that you could take out or put back in. The really great thing about this particular image is that people very, very quickly got the fact that it came through a process, and it could therefore go back through the process to be re-identified. And I think that was a very, very important concept to get across. On the right-hand side, we'd obviously need more than 5 silhouettes, because I don't think that's particularly aggregate. But yes, we would have lots and lots and lots of sort of silhouettes of individuals. So it's clear that the data set is made up of individuals, but you can't tell who any particular one is. The images work really effectively. People got them very, very quickly. Try to map on some language to these images, and the terms that we have at the bottom now are, I hope everyone can see them, personally identifiable. We tried personal, we tried identifiable, we tried other permutations, but personally identifiable was the term that people sort of got very quickly, and they understood not only that it was direct identifiers such as name, address, and so on, but potentially other identifying information as well. Depersonalized is the term that came up best for the middle category, which surprised us somewhat because it's a slightly odd term. But again, it got across very quickly the idea that the data had been through a process, that it wasn't about, it was still about an individual, but it wasn't a named individual, and also that it could go back through the process of essentially being repersonalized in principle. Identified people just didn't get that as quickly or as effectively as the term depersonalized. So we think, given that that's a category that doesn't at the moment have an effective term, we actually think the term depersonalized could be really, really useful to use here. And on the far right, actually, anonymous works pretty well. It works pretty effectively. You could add grouped to it to ensure that people understand that it's about many, many individuals, many people. But actually, anonymous seemed to work pretty well. There is a slight issue with that in that you could have anonymous data that hasn't been through a process of anonymization. It could have just never had identifiers in the first place. So it's still a bit of a challenge, and we're trying to work through that at the moment. Work through thinking about how we could do that. One of the things about this spectrum, of course, is that if you see it as being along a spectrum, is that you can shift along it. So under the new General Data Protection Regulation, a lot of data that would currently be classified as pseudonymized will in likelihood shift towards the personally identifiable end of the spectrum. And using this spectrum and using these images, you can sort of more easily show the dividing lines and show that these things could shift depending on what information is available, also depending on what kind of technology is available. So you could have data that looks like it's depersonalized, but if you apply, if you have other data sets and so on, it will shift more towards the personally identifiable end of the spectrum. And I also think the spectrum idea is extremely helpful for demonstrating to people that these things, they're not fixed, and also that they're about sort of risk-benefits. There is a risk-benefit sort of analysis to be conducted. These things aren't absolutely concrete and black and white and fixed. You're all going to be able to shift things along the spectrum depending on technologies, depending on data sources, depending on the governance you have around the data. It's much easier to explain all those things when you've got this kind of spectrum and you can slide along it in different ways. So that's one of the sort of key outputs we have from this work so far. The really reassuring thing about this approach was that from a very, very brief conversation, people were exposed to these terms. We started off just exposing them to the terms and not even the images for about 5 minutes. After about 5 minutes of having this discussion, they were very accurately able to map different data use to those different levels of identifiability. And it's incredibly reassuring because a lot of previous research has indicated that you need to spend 2 or 3 days with people explaining data use to them before they feel that they adequately understand what could happen to data and all these different levels of identifiability and so on. But with very, very short exposure to them, and we sort of had a spectrum on the wall and asked people to sort of say which degree they thought these different types of data were, and so on. The most problematic examples were ones that involved barcodes and databases. It was really interesting because people were having quite sophisticated, nuanced conversations, for example, about barcodes. Say, is it depersonalized? Is it personally identifiable data? Well, it depends on who's got the scanner. It depends on what other information is contained within the barcode. So very quickly having some quite technically detailed conversations, but after a very, very brief exposure to these terms, which we found very, very reassuring. So That's a whistle-stop tour of the work that we've done so far in understanding patient data. We are formally launching a website at the beginning of April, understandpatientdata.org.uk, which will include these resources, all the work behind them, about case studies, and we will be working up further additional resources in the months to come. But the vocabulary is one of the key things that we've been working on, and we're very keen to ensure both that people find it useful, we're still refining it, so if you do have comments and suggestions about what we could do to refine it, what else we need to think about, they'd be very, very welcome. But yes, these will be sort of open available resources. We're also working as well with Department of Health and NHS England around the images, potentially some animations around the Lego, or they won't be Lego men, to show, say, the processes of depersonalizing data, anonymizing data, and so on. So I think I'll leave it there. Very welcome to have any questions. If you're interested in the initiative, Nicola Perrin is leading it. I'm also part of it, and as I say, our website will be launched at the beginning of April. Thanks very much.
Natalie, thank you very much for beautiful PowerPoint and wonderfully rapid canter through incredibly complicated task. I have to say, when I heard the Wellcome Trust was going to do this work, I was really interested to see how it would play out. And I've had the pleasure of attending the IGA workshop where you and your colleagues again explained it, and it was so well received by the 300 odd people that attended. Anyway, well done and thank you. Now we've got 10 minutes available for people to fire questions at Natalie. After that, we're going to hand over to Trevor, who will talk through the opt-out mechanisms and the development of that. So we already have one question, thank you very much, which I'll read out. As soon as someone steps outside the NHS arena into social care or the voluntary sector, are they still a patient? Are people patients even if they are not receiving care? So actually this hit a difficult thing that you've established a small number of words, but it doesn't fit well with our increasing reliance on the interface with social care and voluntary care. I'm not sure whether you've got an answer to the question.
No, I think that's absolutely right. This is a real challenge, and we really struggled with this because you're absolutely right. As soon as you're in social care, people don't necessarily consider themselves patients. I think this is a problem for the whole of health and social care, actually, how you actually talk to people and about people. A challenge here is trying to find alternatives that people do feel comfortable with, and there was nothing that we found that people felt they understood better than patient. You are absolutely right that it doesn't really fit with social care. I'm not entirely sure what we do about that. I'm also not entirely sure it's a problem that we can necessarily address, because it's an issue for the whole of the health and social care domain. Challenge is, I think we start from a position of helping people understand patient data in the sense of their health record, and people kind of can get a bit more of a thorough grounding in what that means, what information in their medical record could be used for research. It then makes it easier to then extend that into other types of data, into social care data, and so on and so forth. So you're starting from that base. It means you haven't got it right at the outset, but if you're starting from helping people understand how their patient data is used, then you could potentially then expand and say, and by the way, information from your social care record could also be used in these ways, and so on. So it's an imperfect solution, but certainly a real challenge, I think, for the whole sector.
Yeah, a very considered answer. Thank you, Natalie. I mean, from my own perspective, I understand why people said they understand patient as a word and they don't understand social care. Because I have to say, I've had the experience of my father benefiting from social care, and I found it very difficult to conceive of what that would mean until I physically experienced it. And of course, the question of who pays for it, and what the border is between volunteering, friendship, whatever, and voluntary work. So it's a minefield, and I'm just personally very grateful you've brought some clarity to what words work, the public arena. And I know this is really the start of these pieces of work. So do we have any other questions? Yeah, here we go.
I did spot another question, which is about the EU data protection regulation, which I can just briefly comment on, if that's okay. So from Peter, yes, you're right that the EU data protection regulation, which will become law in May 2018, before we finalise Brexit, includes pseudonymised information as defined as personal data, and I think that's actually it's a really interesting development, and I think it goes to show that terms like pseudonymised don't actually help you figure out what the right level of governance is or how you talk to people about what those protections are. If pseudonymised data is going to be considered personally identifiable data, then you need to really carefully consider how you talk to people about that. And actually, I think if it is in that personally identifiable category, it does make things easier, because then you don't have this sort of confusing, messy term that people understand different things by. So it does add this interesting element in the sense that pseudonymised ceases to be useful as a term to describe these different levels of identifiability, and if data would need to be anonymised in accordance with the ICO code of practice to count as depersonalised.
Thank you. Yes, it would pedo into a lot of the different techniques we use currently. If pseudonymization is removed as a tool, it's useful, but of course the law is the law. Another question, which is, did the project test this information approach with children?
No, we had some limited time and resources. The key sort of time driver for this piece of work, which we started in end of October, was assuming that the Department of Health will produce their response to the Caldecott review, and we wanted to ensure that we had some language that could feed into the opt-out and the development of communications material around that. So we were quite pushed for time in terms of the development of this. It meant that we had to be quite restrained in the focus groups and the number of people that we could talk to. So we haven't specifically tested this language with children.
Of course, Natalie. So we've got a series of questions in. One about sending data from to CSUs. That was really a general question on IG. I'm not sure who that's coming from. We do have a query service with the IGA, so you can fire that question to our mailbox as the WebEx proceeds, and maybe we can answer it in short order. We also had a comment that someone has lost sound. That's Patricia Rule. I'm sorry about that, Patricia. Suggest you dial back in, because we're definitely still on the road. Okay, so I've got a general question really for attendees, which is, how does it fall with you? How does it fall with you in your everyday jobs? What do you think about it? Now, I'm going to take off the general mute. We'll do that at the end. So maybe you could either send your thoughts in, everyone, using the WebEx, or till the end and then shout out your feelings and your thoughts on this piece. So I move over now to Trevor Anders, and Trevor's kindly come here from NHS Digital. NHS Digital are the technologists that support the NHS and social care. Trevor and colleagues have been given the task of working up the precise definitions for an opt-out, and then how that could be developed into an architecture and a set of services to deliver the minister's intention, or what we presume will be his intention once the DH has responded to Dame Fiona's challenge. So over to you, Trevor.
Thank you, Stephen. You're stealing some of my thunder there. Good afternoon, everyone. I'm introduced. I'm Trevor Anders, a Programme Manager with NHS Digital, working now on the National Opt-out Programme, with a specific responsibility around local implementation, though I do work across a whole range of strands on the programme. So, I think firstly I'm going to apologise immediately for the language that are used in these slides, having just had that wonderful presentation from Natalie, because I'm using all the wrong terminology. just to reassure people that we are working very closely with Wellcome Trust and looking at how we can build that language and terminology into the things that we do when we start talking about national opt-outs. So I think, again, as Natalie touched on, back in July 2016, the National Data Guardian, Dame Fiona, published a review on data security, consent and opt-out. And today I want to talk to you a little bit more about the consent and the opt-out part. The review recommended a number of things, but three key points that stand out were that citizens should be able to opt out of data uses beyond their individual direct care. The opt-out should apply across the whole of the health and care system, but that needs to be done in an environment where citizens are clear and understand how health and social care information about them is actually used and in what circumstances they can opt out. So a challenge in that. And that went into a public consultation which closed on the 7th of September. And as Stephen said, what we're waiting for now to be able to move forward is the government's formal response to that. And we don't yet have a date agreed with the department as to when that formal response will come out from the Secretary of State. Work has been ongoing to look at the key parts of the review and to make sure that we've got some clear views about the headline policy before that announcement comes out from the Secretary of State. So we can't today give you a date, unfortunately. What we wanted to do was just take the opportunity to reassure you that we know it's been maybe a little bit silent since that review came out and since that consultation came out. So we wanted to make sure you understood that work is ongoing at a pace to actually move forward what we believe we will be asked to deliver. So a national programme has been formed as part of the Paperless 2020 portfolio, which is a collaboration between the department, NHS England and ourselves, NHS Digital. And NHS Digital have got a really leading role in that whole programme of work. So we are developing a whole set of processes and systems, including all supporting communications and training products that we need to be able to implement that national opt-out. So we are looking at systems that will enable citizens to securely set their opt-out preference online, and that's a key focus, that there should be an online presence for this. We also are working on the basis that citizens will still have an option to be able to set their preference by going through a GP practice. But we recognise that citizens also should have another option available to them for those that don't use digital services or cannot use digital services, and also for various reasons are not able or do not wish to go through their GP practice. So we're also looking at alternative solution as well for that. Work preferences are set in a GP practice. We will be putting in place a system whereby those preferences will be updated to a national central store, so there will be a central record of preferences set by a citizen that will be maintained and held by NHS Digital. And the key part of all of this, it's all very well to be able to communicate to citizens and allow them to record their preferences, but you do actually have to be able to act upon those preferences. That is a huge challenge in itself. So we are also working on a range of technical options that we will make available to the health and care sectors that will enable them to actually apply those opt-outs to that they share. It needs to have opt-outs applied to it, so it complies with the basic policy that's been defined for the national opt-out. Really, we just wanted to highlight, we are looking in terms of the approach, we're taking our time to get this right. We're very keen to bring users in terms of looking at systems, communications, processes. We work very closely with service to make sure that we co-develop products, that the communications are right, the training materials are right, the IT solutions and systems are right, and make sure that everybody understands the opt-out, they understand the messages, and that we can share that message in a consistent way across health and care, and the health and care sector can communicate that message in a consistent way with the search users. And we also want to learn from others. So there's already many examples of different data sharing initiatives taking place, local care record schemes, and we are working to work with those particular groups to actually understand some of the pitfalls and some of the issues that they face and make sure this national opt-out can work comfortably alongside those local care record services. Also to recognise that when we talk about communicating, this is part of a wider initiative. We don't want to go out and publicise and push a message about being able to opt out. It has to be a message that's enshrined about data sharing, actually building public trust and confidence in the system. Dealing with it, and we have to make sure that we do is that we don't create a situation where more and more people think they need to opt out, they're not comfortable. And I think the other key thing and the key message to get across to everybody, because I know concerns have been raised, time to implement this, we recognise that we want to take time to get it right. We want to make sure that the health and care sector are able to implement this. And we will be doing this in a phased way, so although the actual ability to record an opt-out will be something that we'll probably have to make available to citizens in England from day one, the actual process of organisations being able to actually uphold that opt-out will be something that will be phased in over a period of time, probably likely through till 2020 in line with the Paperless 2020 programmes. And it will take time to work with organisations to understand where in that spectrum they need to come in terms of when we think that organisation might be ready to bring in and start applying the opt-out. So hopefully that's given you a feel for what we're doing. Very welcome to take some questions. We won't have all the answers today, but we'll certainly take anything away as feedback and work that we can feed in.
Thank you very much, Trevor. So we've had a series of questions, and we're just going to pick up a few of those. Related people, greatly. First one, how does opt-out fit with the ISO for explicit consent? I believe the idea was that data could be used for research.
Okay, I think that's a general question about the policy. So where explicit consent has been given, that would override the opt-out. We're very clear on that in terms of a national policy. Wherever you've got explicit consent of the patient, for a very specific study purpose, and that would always be seen to override the opt-out.
So, for example, I'm a member of Biobank.
And so might be.
So it's 500,000 of us middle-aged, wonderful people, and we're in that space. You're saying that no one is going to mess us around and stop the flow of data?
That's the principle that we are working to, yeah.
Thank you very much. So let's go for another one. Was duration given to aspects of Accessible Information Standard, AIS? So
I'm not sure if this is referring to some of the technical solutions that we're looking to develop in terms of the internet type options. We certainly will be compliant with all the standards there, and we also have to be compliant with the government digital standards as well. So we are still developing these solutions and systems, but we will certainly be looking at accessibility from that aspect, but also accessibility in terms of any products that we produce, so any communication materials. Do you need braille options? Do you need large print and those kind of things? So yes, we recognise that.
Thank you. We've got a really interesting question here about mental health service provision. For patients in adult mental health settings, how will they be able to opt out? And how will independent providers know that patients have opted out when submitting things like the mental health service data set? Another question. I know I had the pleasure of attending a workshop about 10 years ago with mental health patients when they were bringing Connecting for Health in. And the reality about electronic records and their sharing was very locally stated. I imagine those good people are still very upset about it. So another dimension, I guess, for the anxiety and stress that people have as part of mental illness.
Yeah, so
around record keeping.
I mean, I recognise that totally, and we've heard that before with other systems. But you know, I can't give you a full answer today because it is one of those things which is our.
Yes.
In terms of independent providers having access to the information, well, again, anybody in the health and care sector providing data, if it falls within the policy rules of an opt-out being applied, then that provider is actually in scope of having to uphold the opt-out. So we will make the technical solutions available to the providers if they have to apply opt-outs.
Yes.
That's the easiest way I can try and answer that.
And my assumption, Trevor, is that some data flows will not be subject to the opt-out.
Absolutely.
My own assumption, not putting you on the spot is here now, is that one of those opt-outs will be for the financial management of the NHS. But there'll be presumably some very tight regulations on how that data is handled. Because we walk away from financial management.
No, we can't. No, and that's definitely one of our thorny ones. And it's an issue we've already faced with the law of data services coming from regional offices. So there are instances where you can move to more anonymised data, or de-identified data, I should say. But we're looking potentially at some legislation to support some invoice validation type activities. So it's certainly something, again, it's on the policy log that we're working our way through.
I mean, my assumption, and I think you said this at the beginning, is this opt-out will be released very carefully, and there will be associated regulations, in other words, a legal basis for, perhaps a stronger legal basis for some data flows.
We will be very clear about the circumstances and situations in which the opt-out can and will not apply, and we need regulations to actually enforce that. Regulations are being looked at and considered as well that will come in to underpin that.
So just to go through a couple more questions before we open this up for everyone to be able to shout their questions, their pleasure, their horror, where they are on this spring day. So another question linked to that question: what will you actually opt out of? What will you actually opt out for? Talk to clinicians as a user of patient data and genome research. Say GP and hospital data are not linked. I don't know whether you can answer that one, Trevor.
I'm not sure I fully understand the question, but...
Okay, so maybe whoever's asked that question, if you send it into the IGA mailbox, we'll pass to Trevor, and if he can answer it...
What I would say as a more general thing is, and it was in Dave Fiona's recommendation, she pointed out two potential options about what people would directly opt out of. One was for NHS care and planning, and one was on research. And I'm still working through the policy on that, and whether it would be a one or two questions approach. So whether the opt-out will be generally you're opting out of your information being used for research, healthcare improvement and planning, or whether they would be separate things. But even then, as everyone appreciates, I think, on this call, even that's down to a level of granularity, because there will be exceptions, there will be circumstances where it won't apply. There might be a legal gateway in place that means legislation means you have to flow data for this particular purpose. And that is the thorny issue that we have to wrestle with and make sure that everybody understands those rules.
Pictures.
Well, seem to the answer. I'm not. It's a bit tricky to do with pictures, but yeah.
I love pictures. Okay. So I think what we're going to do is we're going to. What future WebEx is on. And now, hopefully Natalie's still on the call. What we're going to do, as well as run the poll, is ask you to come off mute and start firing your questions. So The poll has just opened. We'll run it for 5 minutes. And please, will unmute. And you could unmute and offer any views. We're doing the hubbub now. 100 different work. Sociological experiment. Now you don't have to say anything, but if you do, now's your chance. Got a request to ask another question, please do. As I said, we have unmuted you, so you can say it now. What's the question, please, Vicky?
Hi, Stephen. Can you hear me? It's Jenny Spears.
Yes, we can. From Manchester, I believe.
Yeah, we are. I've got Philippa with me as well, working on the internet. I just wanted a question for Natalie. I think she mentioned the term patient was the first choice. We wanted to know about what the second choice was, if possible.
Natalie, I don't know if you're still on the line.
I am, but I didn't quite hear the question, sorry.
If patient was the first choice in terms of name, what was the second choice? We're wondering about the term citizen here, and obviously that wasn't well accepted. Was there any kind of second one that came running closely?
If you give me a moment, I could just I can go back to the briefing that we had and
We've muted all and just given Natalie the microphone to allow her to answer this question. Thank you very much, Jenny. I can't have a conversation with you anymore, can I?
So the stats we have from the focus groups. So was the question around the overarching term? Patient health. Okay, yes. So the ones we tested, patient data, patient health information. The next most popular one after that was health information about you. After that, your health information. Information from medical records. At the bottom, we had health data, health details, and citizen health information, which was not popular. So after patient data and patient health information about you was the next most popular one. But patient data and patient health information was substantially popular than health information about you or your health information. Does that answer?
Sorry, we muted everyone again, so we've disabled Jenny from speaking. Perhaps we can unmute everyone.
There's another button there, you could start the poll.
Yeah. So I've got another question. This is for Trevor. Is opt-out, as defined here, an objection to processing under GDPR?
Not specifically. So there's work ongoing, as you said, to work policy around this. But we also closely aligned with the work that's going on to understand the GDPR, how that will actually need to be implemented in this country. So it's not we could answer in detail today, but I can't say that the two things are aligned.
Yeah, I have to assume that they will be. I guess we have to. But thank you for being so open, Trevor, about the machinations behind the scenes. If we could see everyone again, Ingrid. No, we can't. Why can't we do that?
The truck will be too much. If anybody does have any questions, feel free to unmute yourself.
Thank you, Ibrahim. He keeps me on the straight path. We've got a few more seconds for the WebEx polling to go. I'm just going to looking for some more questions. I'm going to close it down now and thank again Natalie, Wellcome, and Trevor from NHS Digital. We've had over 100 people on the session. It's been enjoyable for me, and I hope it has been for you. So let's enjoy the sunshine.
Can I just say, if anyone has any questions to follow up from me, then by all means, please get in touch.
Thank you, Natalie. Goodbye.